Good morning, dear students. Now today, I, Dr. Kamlesh Bagmar from Homoeopathic Medical College and Hospital, am going to deliver a lecture on benign prostatic hypertrophy, which is also called as BPH. Now students, this is a very interesting topic and a most commonly affected in elderly people, male patients, those who will come and they will share their experience about the urinary difficulty. See students, the elderly person coming up with a hesitation, lot of hesitation in his mind, and when he is talking about that he is having some urinary problem, it is affecting his life, his quality of life at a very high level. So now the key objective of this lecture should be, upon completion of this lecture, the student should able to identify the common symptoms associated with benign prostatic hypertrophy so that they can able to diagnose the clinical condition, which is knowledge-based objective. The second objective is very important: describe important considerations that will impact the clinician's evaluation of symptoms. Now, most of the time, this condition is affected, is having, along with this condition, you have to differentiate many other conditions having urinary difficulties. So, definitely, the evaluation of the symptom should able to help to diagnose benign prostatic hypertrophy. And the last is amongst the various treatment options available. There are various treatment options which are available in the management of benign prostatic hypertrophy. It may be non-pharmacological, it may be pharmacological, it may be surgical, it may be homeopathic. So, at the end of this lecture, the student should able to tell, convince or may guide the patient which option will be a suitable option for the patient in the management of benign prostatic hypertrophy. Okay, so we'll move ahead so that at the end of this lecture you should able to have these three competency which are at knowledge level, which are at aptitude level, and which are having the skill like digital examination, per rectal examination is again important. Skill of taking a case where the elderly person is having an embarrassment and he is sharing, sir, how should I tell you? Should I tell you? Yeah, I am having a problem in voiding a urine and my urinary flow gets spilled, my cloths get wet because of the urine having not a proper stream, not a proper force. So at that level, the student should able to take a very proper case and diagnose such a condition. So we'll move ahead. Understand the prostate gland. This is one of the accessory gland present in a male genitourinary tract, and it is having three key components. One is glandular component, the another is fibrous component, and the third is muscular component. Now all these three components are very essentially has to be understood because these three components are involved when we are talking about a prostatic enlargement, that too in an elderly person. So here you can see a prostate gland, and where you will find it out, if it is been getting enlarged, it has to create a pressure on the urinary bladder and the prostatic urethra very specifically, and that causes a lot of difficulty for the person to have the symptoms of benign prostatic hypertrophy. Now, this usually benign prostatic hypertrophy develops in the submucosal glands, right? Whereas the prostatic carcinoma, it develops exactly in the glandular region. So that is the basic difference histologically or histopathologically, where we can able to differentiate the benign prostatic hypertrophy and the carcinoma of prostate. Now, there are various terminologies which has been used to indicate BPH. The one is benign prostatic hypertrophy. The another one very commonly used terminology is fibromyoadenoma. The word itself talks about the three things, students. Fibro, that is related to fibrous tissue, myo, related to muscular tissue, and adeno, related to glandular tissue. So, this condition is having an involvement at fibrous, muscular as well as glandular level. It is also commonly being termed by the lay people as an enlarged prostate. The another key entity which is been also the terminology is prostatism. The very commonly the 2 marks question may be asked like what is prostatism, and students may able to write down that this is one of the terminology used for the benign prostatic hypertrophy, which has been indicating frequency, urgency and hesitancy in the urination. Then it is termed as benign prostatic hypertrophy or benign prostatic hyperplasia. When we talk about a hyperplasia or a hypertrophy, that at a glandular level, the lay person may feel that it is a carcinoma. But no, it is not a carcinomatous entity. It is purely a benign entity. It is also called as bladder outflow obstruction syndrome and benign prostatic obstruction, or in medical terminology, very commonly the consultant use the word LUTS, that refers to lower urinary tract symptoms or lower urinary tract syndrome. Now this is the one entity, benign prostatic hypertrophy, where you will find it out lot of symptoms which are contributing at the level of lower genitourinary tract. So lower urinary tract symptoms or syndrome are very commonly the word LUTS is being used to indicate the prostatic hypertrophy. Now if we talk about why we need to understand this topic, as we say, when the people gets elder, their hairs get matured and they get grey, right? In the similar fashion, when you find it out, the elder persons and their vision deteriorates and they suffer from maybe cataract. In the similar fashion, in the male genitourinary tract, you will find it out at the elderly level, the prostate gets hyperplastic. And so it is very common entity. So you will find it out 10% of the people having an age group of 40 to 49 years are suffering from benign prostatic hypertrophy. And even a 40%, it is so common that 40% out of 100 people, 40 people above the age of 70 years has to suffer from benign prostatic hypertrophy. If we talk about the histological prevalence, so as to study a histopathological appearance and to diagnose, 50% of the people in the age group of 50 years will be diagnosed is having a benign prostatic hypertrophy, whereas 85% above the age of 80 years are having the complaints where we can histopathologically diagnose this condition as benign prostatic hypertrophy. Now, in benign prostatic hyperplasia, it is actually a non-malignant growth of a prostate. This is very important, where we as a physician needs to be confident and will share this if to a person his half of the problem, his worry, his anxiety related to age-related carcinomas and malignancies will going to go down, because we have to convince them that it is a non-malignant growth of a prostate which is going to occur. Now, benign prostatic hyperplasia by definition is a chronic condition. It is over a period of a time you will find it out the prostatic hyperplasia develops. So it is a chronic condition that clinically manifests with lower urinary tract symptoms. A very easy definition. So it is a chronic condition, so we need to think about this chronicity when we are taking a homeopathic approach to it. So at various level, like maybe we have to find it out at a symptomatic level, one approach, maybe at the level of miasm, one approach, and maybe related to understand the chronic condition. So chronic constitutional remedy will be the third approach. We are going to talk about these approaches when the management is going to come. But understand the definition per se, we don't have to forget the chronicity where we are having a hyperplasia and which has been reflecting with the lower urinary tract symptoms. Now, benign prostatic hypertrophy, it usually causes the bladder outlet obstruction. That is the key thing where you will find it out that the symptoms are being getting produced. The patient is having a problem because of this outlet obstruction. Now this outlet obstruction can occur when there is a spasm of the urethral muscles. And it again causes, because of an enlargement, because the prostate is giving an pressure over the surrounding tissue, you will find it out that there is a mechanical compression of the urethra. And the prostatic urethra, which has been getting involved and which is the key cause so as to give rise to the various symptoms. Now, if we go ahead to understand the etiology and the etiopathogenesis, pathophysiology, the key cause of benign prostatic hypertrophy is still unclear. But there are many theories which has been prevailed, which has been kept so as to understand why as the age increases, there should be not an hypertrophy but an atrophy of the systems. But here it is a condition where you will find it out the age is increasing and the prostate gland and its size is been getting increasing. So there are two theories which are there. One is termed as hormonal theory and another is called as a neoplastic theory. In hormonal theory, you will find it out as the age advances, the androgen levels of the androgen are going down, whereas the levels of estrogen are getting increased. And this is the key cause few people have put forth as this is the reason why there is a development of enlarged prostate. Whereas the neoplastic theory talks about that there is a proliferative element which is there at the prostate level. As we have talked about, it is all three levels of proliferation which are there. First, fibrous tissue, second muscular tissue, and the third glandular tissue. So apart from the hormonal theory which talks about that the male hormones like serum testosterone, other mechanisms for the benign prostatic hypertrophy which also talks about that there is a stromal epithelial interaction, the growth factors and the age related changes related to estrogen testosterone ratios disturbance can bring on to the enlarged prostate. There are few researches which talks about that the genetic and hereditary factors are also responsible in the presentation, in the formation of benign prostatic hypertrophy. Now if we talk about the pathophysiology, the student should be able to understand that the pathophysiology of prostate doesn't remain at the level of prostate. It gives rise its clinical symptoms at a various level. It may be at the level of urethra, it may be at the level of bladder, it may be at the level of ureter, and not only that, it may be at the level of kidneys. Because of the compression, because of the pressure, because of the spasm, all these things are being getting affected. So if I need to understand the symptomatology, I have to understand that prostatic enlargement compressing the urethra, prostatic urethra, and giving rise to an outlet obstruction symptoms are causing a pathophysiology at a various levels. The first pathophysiology where you will find it out is the compression of the urethra, right? So the compressed urethra can bring on to the various, it starts with the various trouble. Second is the key thing which develops is in the urinary bladder. Now in urinary bladder, you will find it out, the first thing what it will develop is the hypertrophy of the bladder muscles. Along with the enlarged prostate, with the compression of the urethra, the bladder size and the bladder's hypertrophy is there. Now once this bladder hypertrophy of the muscles is there, it causes further obstruction and causing the stagnation of a urine. So there is a voiding problem and the urine is been getting accumulated inside the urinary bladder. Now this stagnated urine will be a source of UTI, that is urinary tract infection. So, and further to this infection, you will find it out the organisms develop, pathogens develops in this stagnated urine and can be a source for a formation of infective vesical calculus. So understand that in urinary bladder, the prostatic hypertrophy can cause level of changes from the hyperplasia of a bladder muscle till the obstruction, stagnation, infection and the formation of urinary calcula, vesical calcula. Now, in the urinary bladder, there are two things after the hypertrophy of a bladder muscle that develops and which are very key, and one needs to have a focus on it, because whenever we are advising an ultrasonographic examination to diagnose the benign prostatic hypertrophy, we have to look for these two words in the sonology report. The two key words are trabeculations and saculations. Because of the hypertrophy of the bladder muscle, initially they starts with an irregular pattern of the inner mucosa and giving rise to trabeculations, but later on they are being getting formed into a saccule, and once this sacculation is being formed, there are chances of PVR, that is post-void residual amount of an urine will be significantly increased. And so these sacculations, once it has been developed, here we are talking about, if I have to correlate it with a miasm, yes, we are talking about a hyperplasia and a stagnation and a saccule formation. It is all talking about the cytotic phenomena. So understand that we can, understanding this pathophysiology should help to integrate the miasm, to integrate the homeopathic approach and to understand the further clinical symptoms which have been developed. So, the hypertrophy of the bladder muscles giving rise to trabeculations and sacculations. These are the first level and second level. Now, once it has been again not been treated, overlooked, or the level with which it will develop is the diverticuli formation. So, if you see a diverticuli which have been noted into the urinary bladder, it is really, we are talking about an advanced case where the benign prostatic hypertrophy has developed. Now, these diverticuli or sacculation will also be responsible for the stasis of urine and also will be responsible for the urinary tract infection. Now, what happens to the ureter and kidney? Definitely there is an obstruction below at the level of urethra. The bladder muscles are increased and having an pressure, so again there is an obstruction. Naturally this obstruction will be getting ascended and you will find it out that even the ureter is been getting stagnated with the urine and causing a bilateral hydronephrosis and hydroureter. So hydroureter and hydronephrosis. Now when we dealt with hydronephrosis as a topic and renal calculi, you might have understood the significance of hydronephrosis. Because once there are again the three levels of hydronephrosis, mild, moderate and severe. Now these hydronephrosis will going to cause the pressure, and this pressure will going to cause an atrophy of the renal functional tubules, and once it is been developed, it will slowly going to deteriorate the renal function. So this is a very key thing what we have to understand in the sonology report. Enlarged prostate along with mild or moderate or severe hydronephrosis, and our approach and our understanding will going to change. If it is a severe, yes, definitely one can opt for a surgical intervention. If it is a mild, one can opt for a homeopathic intervention. If it is moderate, one can have, along with homeopathy, a pharmacological intervention. So our approach we are going to decide it based on till what extent the pathology has been created because of the enlarged prostate. If still it is been there, ultimately at the end level you will find it out, it may land up and can cause a renal failure. So now coming to the clinical features. Now the clinical features here is the triad. The key triad in the benign prostatic hypertrophy will be related to frequency, urgency and hesitancy. It is very easy to remember. Frequency, urgency and hesitancy. The elderly people, maybe above the age of 50, 60, 70 years, coming to you and sharing that they are having a frequent urination. Initially, the frequency of the urination will be in the daytime. But as the hyperplasia of a prostate develops and it grows, you will find it out that this frequency is not limited only in the daytime, it is been increased at the level, you will find it out even at the night time. A 60-year male, 70-year male, waking 5 to 10 times at a night time, and he has to void the urine. Definitely, there are other probabilities. Differential diagnosis should come to your mind apart from the diabetes. In an elderly person, the commonest will be the benign prostatic hypertrophy, where you will find it out the frequency of the urination is there because of the inadequate drainage of the urine every time which is there. Because the stagnation of urine is there, so naturally the prostatic urethra which has been getting involved and it creates a second level of urgency. Now, even though a very small amount of a urine is been getting accumulated into the bladder, because of the prostatic urethral involvement, you will find it out that there is an urgency for the urination and he cannot wait. An elderly person who cannot wait and he has to go very often and urgently. He cannot wait. He is having an urgency and he has to immediately go to void the urine. The third level is the hesitancy. You will find it out that they are very much hesitant because of ineffectual urge. And usually these hesitations to the urination is till such a level that it affects the quality of a life in an elderly person. Now, in an elderly person, if the patient is feeling a discomfort, how should I go? Just now, before 2 minutes, I went to void the urine. Now again I have to get up. I have to disturb all my family members. It is not good. So, this kind of a feeling which is affecting his quality of life because of the triad of frequency, urgency and hesitancy. And once you will find it out, the prostatic hypertrophy develops, you will understand that it can land up into acute urinary retention. And if not treated, it will further move rise to a chronic urinary retention. So again, in an approach, I need to treat the symptomatic level will be the one approach. If there is an acute urinary retention in a benign prostatic hypertrophy, I should have the skill to treat acute urinary retention. So for that purpose, I should know how to treat acute urinary retention. So at that time, you have to understand that the involvement of clinical skill of putting Foley's catheter is essential. That one has to understand. And in chronic urinary retention, how to treat? Is it at the level of pharmacological level, or we have to move ahead with the another level, maybe at the level of dialysis or certain surgical intervention? So that one has to need to take care of. Now these symptoms of hesitancy, frequency and urgency, along with the straining, he has to strain to void the urine. And very important is The patient will not tell you. We need to ask. We need to be confident at that situation, and would like to give the person a confidence and try him to share his problem. And then he will tell you that yes, my urinary stream is very weak. The flow is very weak. Usually the patient in his own language will tell you, sir, माझी धार माझ्या पायावर पडते. And this is a diagnostic terminology. If the urinary stream, the flow is weak, and he will tell you, I have to wait till the complete voiding of a urine, and it takes a time. So prolonged voiding of a urine. It may be partial or it may be a complete urinary retention. Very small voided volume of a urine. Nocturia. I have to go frequently at the night time. And later on, there is dysuria also. Painful urination. So, to have all these level of a symptom, the physician should able to differentially diagnose this condition having lower urinary tract symptoms. It can be non-specific also. It can also be included with prostatitis, that is inflammatory condition which has been involving the pathogens. It may be all the symptoms will also guide you, indicate you that the patient may be having a prostatic cancer. It may be a bladder outlet obstruction like urethral stricture, or it may be a urethral stone, obstructed stone. So all these differential diagnoses one needs to take care while dealing with benign prostatic hypertrophy. Now if we talk about, there are solitary nocturia, only urination, frequency of urination at night, the urgency, dribbling and weak stream force are the key component prevalent symptoms which has been observed in the researches. So we need to concentrate on these four symptoms. What I will say is solitary nocturia, urgency of urine, dribbling of urine and weak urinary stream force. Now to diagnose benign prostatic hypertrophy, the student should have the skills related to history taking. So first thing what they should get straight, whenever the LUTS, lower urinary tract symptoms comes, the physician should have a confidence and will allow the patient to express his problem. So history taking skills are important. The assessment of the symptoms and the quality of life is again important. Nowadays there are many questionnaires which are available which can help you to diagnose the quality of life affected in benign prostatic hypertrophy. Apart from that, the third key thing what the student should be able to understand while diagnosing this condition is the examination. And this examination is very important, we call it as digital rectal examination. Like in obstetrics and gynecology, we are using the word PV, per vaginal examination. Here, for a prostatic environment, we are using a PR examination, that is per rectal or digital rectal examination. The next thing which should help you to understand is the urine analysis, where we are talking about that the infectivity is there or not there, or the other symptoms like RBCs, presence of the blood cells in the urine has to be again understood in a different way. The estimated glomerular filtration rate, that is eGFR, is suspected when we are talking about there is a renal impairment. The very good diagnostic tool to diagnose prostatic hypertrophy is ultrasonography. Now in USG, we need to understand few keywords. Like I said, trabeculations, saculations, diverticuli formation, and the fourth keyword will be the post-void amount of a residual urine which has been lying there. Right? So the keyword the physician should read is how much amount of a post-void residual urine is being left to diagnose that it is a prostatic hypertrophy. In few cases, we have to move ahead with uroflowmetry, and another key thing is serum PSA, that is prostate specific antigen. So these investigative parameters will help you to diagnose and to differentiate all the related clinical condition and come to the final diagnosis of benign prostatic hyperplasia. Now in serum investigation, there is one key investigation which has been performed, is serum acid phosphatase level. The normal value of serum acid phosphatase is 0 to 5 King Armstrong unit, which is a normal value. It does not increase in the benign prostatic hypertrophy. Keep this in mind. If I have to differentiate a benign prostatic hypertrophy from the prostatic cancer, you will find it out that serum acid phosphatase should help you to differentiate, as serum acid phosphatase remain normal when we are talking about a benign prostatic hypertrophy. But in case of carcinoma of a prostate, it is significantly been getting increased. So serum acid phosphatase. The second investigation which we have just talked about is the serum prostate specific antigen. So it is a very organ specific antigen. It means it is talking about the prostate, and the prostate specific antigen, the normal value is 4 nanomilligram per ml, and if it is more than 10 nanomilligram per ml, then it is significant. But one thing we need to make sure that serum PSA values will also be raised in various clinical conditions like prostatic cancer or hepatic cancers. Now, what we have talked about is digital rectal examination. So this is a one very skillful examination. Maybe very people will not like to, but we have to convince him. We have to tell them politely how the procedure will be, take a permission, wear a gloves, have a proper lubrication. After taking a consent, we have to slightly slowly insert the finger, index finger into the rectum so as to feel the prostatic gland from the rectum. Now you will find it out in benign prostatic hypertrophy. Significantly you will come across that the prostate is being enlarged, and you can easily palpate the prostatic enlargement from the per-rectal examination. Whereas in carcinoma of a prostate, you will find it out the consistency of a feeling from the per-rectal examination will be very hard. Where you can think of conium is a very good drug when we talk about, which has been related to not only the glands, hyperplasia, carcinoma, but the hardness, the stony hardness. So you need to understand the various level where we are talking about. We are examining a prostate, the feeling of hardness, and the drug will also going to change. The diagnosis will also going to change. Now what is this post-void residual amount of urine? So once the sonologist is performing and with a full bladder sonography, he will find it out that the bladder is full. So the sonological waves are very appropriate, and it will help the sonologist to understand the structures. He allows them to go and void the urine, and immediately once he has been voided the urine, he has to come again and he will find it out, is there any residual amount of a urine which has been lying in the urinary bladder or not, which has been called as the post-void residual amount of a urine. So, but mind it well, the post-void residual is being influenced by the unfamiliar surroundings. So, the volume of the urine which has been left in the bladder immediately following the completion of a voiding has to be measured. Less than 100 ml may be a normal limit, but if it is more than 200 ml, yes, we need to suspect the prostatic hyperplasia or the various clinical condition where there is an outlet obstruction is there. And again, the presence of a bladder diverticula are key in diagnosing the benign prostatic hypertrophy from ultrasonography reports. Now coming to the last part, which is very important, is the management. Now in management, you will find it out the key thing in the management is, if there is no obstruction and very limited discomfort, there is no need to go ahead and give modern pharmacological therapies. Definitely not. Why? We will share again. But if it has been initiated, now in homeopathy we are talking about a diathesis. So before the clinical condition sets in, before we have diagnosing, we are trying to find it out that the patient is having a scrofulous diathesis, where there is an enlarged glands. So definitely at that level, if we can treat, yes, we are avoiding the further progress and the proliferation of the prostatic tissue. So there is a lot of scope for the homeopathic management when you are coming across a very initial stage where there is no obstruction as such and having a very limited discomfort. The current management of benign prostatic hypertrophy is focused on relieving the symptoms and improving the quality of life. Now you have to underline this statement. Here we are talking about that this management is now focusing on just to get rid of symptoms, relieve the symptoms, and to improve the quality of life, and they are not asking to go and get it operated. So this is very important that the current management of benign prostatic hypertrophy is completely focusing, because in the elderly person, if he is having certain another medical conditions which is they may be related to cardiovascular or may be related to diabetes, so there is definitely certain contraindications to move ahead and get it operated. So it is better to focus on how one can relieve the symptom and how one can improve the quality of life of elderly people. The non-pharmacological management, which even Dr. Henneman advised that one should be taking care of, should be, if the mild symptoms are there, then watchful waiting and annual evaluation. So definitely, being a homeopath, we can prescribe even before the clinical diagnosis develops, because we are talking about the initiation of the disease in a diathesis form. So we have to watchful wait, evaluate timely, and we have to modify certain lifestyle so that the discomfort should go down. The people should advise to avoid the fluids prior to the bedtime or going outside, so that the outflow obstruction should not overpower them to have urgency, frequency and hesitancy. One should reduce the caffeine and alcoholic beverages, because it will increase the urinary amount of and production of a urinary flow. The scheduled urination at least once every 3 hours. We need to train the people that okay, after every 3 hours the people should go and get the urine void out. Double voiding is again a very key indication where one in the key management procedure, where we have to tell the patients after urination just wait and try to urinate again, because otherwise they are going to have the urgency which is there. In modern pharmacology, there are 2 levels of the treatment which has been carried out. One is at the level of alpha-1 adrenergic antagonist and certain anticholinergics. But both of these drugs having a lot of side effects, and they are very extensive. They can be at the level of dry mouth, blurred vision, tachycardia, constipation, hypotension. Specifically, alpha-1 adrenergic antagonists are known to produce an hypotensive attacks, and again anticholinergics will also affect the urinary functions, genitourinary functions very commonly. So these are the pharmacological therapies which are available. One needs to have a skillful intervention when we are having an acute urinary retention, as I said. So a skill of catheterization with Foley's self-retaining catheter. One has to move ahead with 12 or 14 numbers catheter only in acute urinary retention, where one key thing is only you have to instill a 5 ml of a distilled water in a Foley's catheter balloon. Usually we are instilling 10 to 15 ml of an water so that it should have a self-retaining process. But here in the prostatic hypertrophy, in an acute urinary retention with prostatic hypertrophy, we have to instill only 5 ml of a distilled water. Now if the non-surgical measures fails, the pharmacological measure fails, or if the condition is in advanced stage, where quality of life is very deteriorating, where I am suspecting the patient is going ahead with a chronic renal impairment, and the eGFR is being very diminished and having a renal failure like status, so one need to move ahead with a surgical intervention. Now these surgical interventions will be minimal invasive surgery nowadays, which has been coming up, open prostatectomy, or even endoscopic procedure like TUR, transurethral resection of a prostate. So all these surgical modern technologies which have been available as a management part. Definitely, maybe in the next lecture we should able to tell you that how one can move ahead and have a approach, homeopathic approach for the management of prostatic hypertrophy. So in the today's lecture, what is take home message, or if we have to recapitulate what we have learned, it should be, it is a age progressive disease, its symptoms are variable, and the assessment is key to diagnose this condition based on urgency, frequency and hesitancy of a urination. It is having a great impact on the quality of a life in an elderly person. And there are various treatment options are available. So we need to educate our patient that it is not only a surgery, it may be a medicine, and if medicine are failing, if the condition is worsening, then only one can relate it upon the surgical intervention. So coming to the summarization, so if we need to summarize, our objectives were to identify the common symptoms associated. So I will again repeat. The common symptoms which can help the student to diagnose is frequency, urgency and hesitancy, weak urinary stream, very important. If one need to understand what are the considerable level of an evaluation of the symptoms, so if you are finding it out the lower urinary tract symptoms which are there, definitely it will help us to diagnose the quality of life which has been affected, along with the urinary outflow obstruction symptoms, and the various treatment modalities which are available will be non-pharmacological, homeopathic, pharmacological and surgical. Right? In MUHS you will find it out that there are various questions which has been related to this topic can be asked, like name the gland which hypertrophies with the advancement of age, and only gland we will find it out will be the prostate. So for 2 marks you will find it out such a question. Name the 2 investigations to be carried out in benign prostatic hypertrophy. The commonest should be ultrasonography, and one can think of it is related to prostate specific antigen or post-void amount of an urine in the ultrasonography. What is prostatism? Again, it is a triad of symptoms where we are talking about urgency, frequency and hesitancy in the clinical condition of benign prostatic hypertrophy. So these are the likely questions for the 2 marks. Now one can ask an LAQ for 10 marks in the way describe benign prostatic hypertrophy with its etiology, clinical features, diagnosis and management. And they will also write down, add note on 2 homeopathic drugs for the same, like give indication of conium or subarsoruleta in the cases of benign prostatic hypertrophy. One may going to find it out that the question in the form of a clinical based scenario, like 70-year-old male coming up with urgency and hesitancy of an urination, and in sonography we will finding it out, and mild prostatic enlargement, how you approach to such a clinical condition. Write down your differential diagnosis and management can also be asked. Right? So thank you for the today's lecture, and in the next lecture we shall talk about the homeopathic approach in the management of benign prostatic hypertrophy. Thank you.